Very good morning, everyone. So today we will be revising about internal medicine and pediatrics. In internal medicine, the top priority should be given for endocrinology. Endocrinology is the most important subject for FMGE students, for PG students in surgery or in medicine, wherever it is. Endocrinology is the most important topic. So we'll start with endocrinology because we have got 3 hours for today. So 2 hours I will take to cover medicine and then 1 hour session for pediatrics. I'm trying to finish and I plan to discuss only endocrinology for internal medicine since it's the most important topic. Maximum number of questions for internal medicine is going to be coming from endocrinology. So we'll start with diabetes mellitus. If anyone has planned to leave the subject to leave internal medicine, please just concentrate on endocrinology. It's surely going to give you 10 to 12 marks if you study it. Diabetes mellitus. Is the screen visible to everyone on the writing?
Yes, sir.
Okay.
Yes, sir.
Classical symptoms. Classical symptoms of diabetes. It's going to be polyphagia, polypsia, polyuria, and weight loss. How do we diagnose diabetes? Diagnosis. The classic symptoms should be present. Those polyuria, polydipsia, polyphagia, weight loss should be present with plus a random blood sugar. How much random blood sugar is needed to diagnose diabetes? Anyone? More than or equal to how much value? Yes.
140, sir.
6.5.
200.
HB1AC is more than, okay. AC is more than, okay.
Sorry.
No, sir, if it's HbA1c, no, sir, if it's HbA1c, it should be more than 6.5.
Yeah, HbA1c is also correct. What about fasting blood sugar? How much it should be? More than how much to diagnose diabetes?
126. 126.
Yes, very good. This question has been asked in the exam. FBS more than or equal to 126 milligrams percentage. And if it is a asymptomatic person, HbA1c more than or equal to 6.5 percentage is also going to be diagnostic of diabetes. HbA1c, it is a retrospective test It is going to give you a sugar value for the past 3 months. Then we go for types of diabetes. Type 1, diabetes mellitus. Insulin is secreted by which cell in pancreas?
Beta. Beta.
Very good. What about alpha cells? Alpha cells secrete which one? Which hormone?
Glucagon.
Glucagon. Correct.
Glucagon.
Very good. So beta cells of pancreas is going to secrete the insulin, and in this insulin is going to help your glucose to enter inside the cell of the body. So if this beta cells of pancreas are damaged, beta cells damaged, if there is damage more than 80%, then your clinical features will appear. And for the release of insulin, which ionic channel is important? Can anyone tell? One-liner question. Important. Yes. Potassium channel helps in release of insulin in circulation. Very important. In physiology, you would have learned acetylcholine. There will be acetylcholine vesicles, and there will be bombardment, and these vesicles will be released as acetylcholine. For the release of acetylcholine, which ionic channel is important? Ionic channel will be present here. What
Sodium.
channel?
Sodium.
No, not sodium.
Calcium.
Yes, correct. Very good. Calcium. And this process is called as, in physiology, what do they call it? Exocytosis. Release is called as exocytosis. Something is uptaken, then it is called as endocytosis. Like in case of infective organisms enter in the body, WBC phagocytes are going to eat it. So that is called as endocytosis. Both for exocytosis and endocytosis, calcium channel is very much important. And here, acetylcholine release, calcium is important. This has been asked as a physiology question. And here, potassium channel helps in release of insulin in circulation. Beta cells, masses damaged or reduced, then the production of insulin decreases, then there is going to be a insulinopenia, and that is type 1 diabetes mellitus. Most common cause, yes, anyone? Most common cause for type 1 diabetes mellitus?
Autoimmune, sir. Autoimmune.
Very good. Autoimmune. The HLA associated are HLA, DQ, DR3, DR4. Very important. Autoimmunity is the most common cause for type 1 diabetes mellitus. Our own T cells, our own cells of the body is going to attack your beta cells, going to damage, destroy it. Few infections can destroy your beta cells. Anyone? Microbiology.
Coxsackie B virus. Coxsackie
Very
B
good.
virus.
Then mumps and rubella. Then we have bronze diabetes because of the excess iron. In bronze diabetes, there will be bronzing of skin or hyperpigmentation will be there because of the deposition of iron. Liver cirrhosis, beta cell mass is going to be decreased, leading to insulinopenia or type 1 diabetes mellitus. And the treatment for type 1 diabetes mellitus is going to be carbohydrate counting or carbohydrate reduced diet. And what route we give insulin? IV, IM, ID. Yes, very important.
Subcutaneous, sir.
Very good. Subcutaneous. In the abdominal wall. Site of insulin injections given are around the umbilicus, the arm, and the anterolateral aspect of thigh, or on the buttock. Then we have type 1.5 diabetes mellitus, also known as the LADA or latent autoimmune diabetes in adults. It is a variant of type 1 diabetes. The antibody is anti-GAD or anti-glutamine acid decarboxylase antibody. Also, there is anti-islet cell antibody or ICA, anti-ICA. This anti-GAD is also seen as a manifestation of oat cell lung cancer, that is paraneoplastic manifestation of oat cell cancer lung, and this is called as stiff person syndrome. The treatment, same insulin, as a DNA recombinant technique. Route, subcutaneous. We have different varieties of insulin. Rapid acting insulin, Lispro, Aspart, Blue Lysin. All these are given in subcutaneous route and given 15 to 25 minutes before the meal. We have long acting insulins, Glargine and P-Gludac. Glargine acts for about 24 hours and D-Gludac acts for more than 24 hours. Ramlintide is a drug that can be used for both type 1 and type 2 diabetes mellitus. Pharma question, very important. Which drug can be used for both types of diabetes is going to be Ramlintide. We also have the regular insulin. Regular insulin can be used as IV, can be given IV in case of managing hyperkalemia. Repeatedly, they have asked this question. They will give you a case question, like in case of a patient suddenly having a arrhythmia and with ECG changes, and the potassium levels has been elevated, what will be the management? Emergency, you're seeing the patient, what will the management? So the treatment is going to be regular insulin given as a IV route in case of diabetic ketoacidosis. This is regular insulin treatment for hyperkalemia, very much important, please note. Then we have type 2 diabetes. Type 2 diabetes mellitus cause is going to be polygenetic. Many genes are going to be involved, and the main pathology is going to be the insulin resistance. Here the beta cells of pancreas is functioning normally, but the receptors is going to be resistant. Treatment for type 2 is going to be diet control. In case of carbohydrate intake should be reduced. Then exercise. And then we have the oral hypoglycemic drugs. These drugs will inhibit hepatoglucogenesis, liver, glucose genesis going to synthesize. So the liver is going to produce sugar. In type 2 diabetes, you can see insulin resistance. If there is resistance of insulin, your glucose cannot go inside the cell. So our body thinks that there is no sufficient glucose in the blood. Our liver is going to you must have learned in biochemistry gluconeogenesis. In gluconeogenesis, with the help of protein, with the help of lipid fatty acids, body is going to synthesize glucose. So here in diabetes, the same thing happens. Your liver is going to synthesize in all ways, like with the help of fatty acids, is going to synthesize glucose. With the help of proteins, is going to synthesize your glucose. So already in the blood, glucose is in excess only. The insulin couldn't act. Since the insulin couldn't act because of the insulin resistance from this oral hypoglycemic drugs. Yes?
sir.
Okay.
Yes, sir.
So the oral hypoglycemic drugs mainly is going to inhibit your hepatoglucogenesis. Hepato meaning liver, glucose meaning glucose, and genesis going to be synthesis. The liver is going to increase the glucose levels. Why is it happening? Because in diabetes, your insulin is going to be decreased as the beta cells are destroyed. In case of a type 1, in case of type 2, the insulin is not able to act because of insulin resistance. Insulin is needed by our body for the uptake of the glucose into the cell. So glucose is going to be increased in the blood, but it couldn't be utilized by the body. You must have learned in biochemistry all those glucogenesis, gluconeogenesis happening in liver, kidney, skeletal muscle. So the body thinks there is not enough glucose in the body, as the glucose is not being uptaken by any cell. The liver thinks so already glucose is increased, and hepatoglucogenesis is also going to increase your glucose, leading to which can complicate to diabetic ketoacidosis. So hepatoglucogenesis should be stopped, and to inhibit that, we have the drugs called oral hypoglycemic drugs, and the most important oral hypoglycemic drug for now is biguanides. Biguanides is going to decrease the inhibit the glucogenesis, and the biguanide name of the drug is metformin. It is excreted via kidney. The question says type 2 diabetes mellitus and a obese male or a female, what is the drug of choice? Is going to be metformin. If type 2 diabetes mellitus person who is obese and has a nephropathy or a CKD or a kidney problem, metformin should not be given. And for them, linagliptin, glipizide, tolbutamide can be used, because these three are excreted via, metabolized via liver and not by the kidney. Next, we have the complications. Diabetic retinopathy. Severity of diabetic retinopathy is directly proportional to the duration of diabetes mellitus. And diabetes, if anyone is having a diabetic and they are having a HbA1c more than 7%, they're surely going to develop your diabetic retinopathy. And we learned diabetic retinopathy very well in ophthalmology. Microaneurysm is the most common and the earliest, and it is seen in the inner nuclear layer of the retina. And we have two types, non-proliferative and proliferative. Non-proliferative retinopathy, the visual loss is due to the macular edema because of the water entry into the macula. And the proliferative retinopathy, there is going to be neovascularization, NVG, neovascular glaucoma is going to happen, vitreous hemorrhage, tractional retinal detachment. All these are ophthalmology. We have covered it already. And the treatment, pan-retinal photocoagulation. What laser is used for pan-retinal photocoagulation? Yes. Yes, correct. Nd:YAG laser. And the drug anti-VEGF. VEGF is vascular endothelial growth factor. This VEGF is going to increase your neovascularization, and to inhibit that, we have anti-VEGF monoclonal antibody drugs, bevacizumab and ranibizumab. Coming to diabetic nephropathy, sensory nerve is most commonly affected. Next to motor is affected. Next, autonomic nervous system is affected. And the sensory, first affected sense is going to be the vibration. Some patients, diabetic patients would have told us that they have a pain in feet at night. And this pain in feet at night is most commonly due to the C fiber. You would have learned in physiology, A fibers, small unmyelinated, D fibers, C fibers. So here the small unmyelinated C fiber is involved, and it's also been asked. The treatment for diabetic neuropathy is going to be duloxetine, pregabalin, and amitriptyline. Clinical future, pain is not going to be sensed by them, since the pain sensation nerve is going to be damaged. The nerve carrying the pain sensation going to be damaged, and in the local tissue, the sugar level is going to be high. In case of motor component, cranial nerve, third cranial nerve is most commonly involved, and the autonomic component we have important term silent MI, and it's called a silent MI because in myocardial infarction usually we have chest pain as a complaint, shoulder pain as a complaint. But in diabetics, who is going to get a MI or a heart attack, they are not going to complain any pain because clinical feature we learned sensory involvement. Because of that, sensory nerves are damaged. Pain is not going to be carried by any nerve, and the patient is not going to sense the pain. And the myocardial infarction is going to be happening very much silently. Hence the name silent MI. Then we come for diabetic dermopathy. We can easily know the non-healing ulcer. A patient gets wounded by a thorn or by a stone, and the wound is not going to be healed, and it's going to develop into ulcer. So this non-healing ulcer, and we have the important images in dermatology, or they can give you as a medicine question too. Acanthosis nigricans. It is seen in type 2 diabetes mellitus as a hyperpigmentation patch seen on the back of your neck. Very much important image-based question. The acanthosis nigricans is also seen in PCOD and in CA pancreas. We also have necrobiosis lipoica diabeticorum. These are the skin manifestations of diabetes. Next I started parathyroid gland. So parathyroid gland functions. Okay. So what does the parathyroid hormone do on the bone? Anyone?
Hemostasis.
Calcium?
Hemostasis.
Hemostasis. Okay. Tell me whether calcium values is going to be increased or decreased in case of hyperparathyroidism. There is hyperparathyroidism. The parathyroid hormones are increased.
Decrease, sir.
Decrease. No. Okay. So as far as the endocrinology, this thyroid gland is concerned, you should very well know the functions of that concerned gland. Sure short question is going to be come from parathyroid, either parathyroid or thyroid, as in the form of hyperparathyroidism or hyperthyroidism. Please just know the function. You can very well understand the concept. You have to build the concept. I will tell you how to build it. I will teach you, and please grasp it and apply in your question. Learning endocrinology is surely going to help you for your PG preparation also. In postgraduate NEET exam, maximum number of questions has come from endocrinology in internal medicine, surgery, pharmacology, physiology, anatomy. So endocrinology is that much important. So the function of parathyroid gland is going to increase the resorption of the bone. Increase the resorption. Increase the resorption of the bone, thereby increasing your calcium levels. This is the normal function. And on the kidney, on your proximal convoluted tubule, this parathyroid hormone is going to act on the phosphate pump, and it's going to increase the excretion of phosphate. If there is excretion of phosphate, the phosphate level is going to be increased or decreased in the blood. Yes. This parathyroid hormone is going to act on the PCT, and it's going to help in increase in excretion of phosphate. What will happen to phosphate levels in blood?
Decrease, sir.
Whether it will increase or decrease. Yes,
Decreases.
decreases. Correct. So phosphate level is going to be decreased. This is the parathyroid hormone function. Parathyroid hormone is normally going to increase the calcium and it is going to decrease the phosphate level. So what will happen in case of a there is hyperparathyroidism. What will happen to calcium and phosphate? There is hypoparathyroidism. What will happen to calcium phosphate? Yes. In case of hyperparathyroidism, calcium level is going to be
Increase.
increase or decrease?
Increase.
Increase. Very good. And phosphate?
Decrease.
Decrease.
Good. In hypoparathyroidism, calcium level is going to be
Decrease.
sorry,
Decrease.
decrease. Very good. Decrease, and phosphate level is going to be
Increase.
Increase.
increased. So just by knowing the function, whether the parathyroid is going to act in the bone, is going to increase your calcium, is going to act on the PCT of the kidney, and it is going to increase the excretion of phosphate, thereby decreasing the phosphate. Just by applying this concept, you can know what is going to happen in hyperparathyroidism and what is going to happen in hypoparathyroidism. Okay. So there is going to be increase in calcium. This increase in calcium can manifest as different forms that we will learn next. Can lead to a nephrocalcinosis, can cause constipation, it can increase your blood pressure. So we have hyperparathyroidism. Did you guys understand this concept? Parathyroid hormone, hyperpara and
Yes.
hypopara.
Yes,
Okay.
sir.
Good. So in primary or a secondary, any type, the hyperparathyroid gland is going to be increase in size, bigger. The normal, what is the normal calcium level? It is 9 to 11 milligram percentage. If it is going to increase to 11 to 12 milligram percent, there is going to be nephrocalcinosis or renal colic, constipation because of the spasm due to calcium, spasm of the sphincter controlling the gut. There can be hypertension. There can be psychosis too. And the psychosis is termed as the moaning and groaning. If the level is going to increase to 12 to 13 milligram percentage, we are going to have secondary Parkinson's, manifestation of Parkinson's, bradykinesia, cogwheel rigidity. What's the name of the tremor you get in Parkinson's?
Fine
Neat.
tremor.
Resting tremor. Resting tremor, yes. But what is the correct classical name given to that tremor? Pill rolling tremors. Pill rolling tremors. And if it is going to increase to 13 to 14 milligram percentage, we are going to have arrhythmias, and systolic arrest is going to happen. Investigation, if taken, in case of hyperparathyroidism, serum calcium is going to be increased or decreased. In hyperparathyroidism,
Increased.
phosphate
Decreased.
decreased, and serum parathyroid hormone assay is going to be, parathyroid hormone is going to be,
Increased.
yes. And if there is a tumor located on the parathyroid gland, to localize that, tumor localization is done with the help of a important scan. Anyone? Radio
Iodine.
nucleotide
131.
iodine. No,
120.
123.
not iodine. This is technetium. Yes, EC99. Yes, correct.
99.
Sesame B. Technetium 99 is used, Sesame B scan, and the treatment is medical stabilization. First, we should infuse normal saline. Dilution should be done because in hyperparathyroidism, because if increased calcium levels, there is going to be dehydration. So hydration is important, and also dilution is going to cause dilution effect. Dilution effect is nothing but if you are going to increase the volume in the blood in our body, eventually the calcium level is going to be coming down comparing with the fluid that was present before infusion of normal saline. So that is dilution effect. Then we have furosemide. Furosemide, what drug it is?
Loop diuretics.
Loop diuretic.
Yes, correct. And what does furosemide do with calcium in the loop? Whether
Calcium
furosemide is going
excretion.
to excretion, correct. So furosemide causes calcium loss in urine. So we are having increase in calcium. So furosemide can cause calcium loss. So furosemide can be used. We also have IV ibandronate, alendronate. These are the drug of choice. We also have calcitonin nasal spray. Calcitonin is also a hormone, and it's also going to decrease your calcium levels. And in case of tumor, surgery, resection of the tumor or a adenoma. So this is hyperparathyroidism, and next to hyperpara we have hypoparathyroidism. The most common cause for hypoparathyroidism is going to be autoimmunity. Autoimmune cells are going to destroy your parathyroid gland, and thyroid surgery, and because of the proximal location of the parathyroid gland and inadvertent, there's going to be an inadvertent parathyroid resection. And Digeorge syndrome. Yes. What happens to Digeorge syndrome? Thymus and parathyroid gland. Anyone?
Thymic
T cells will be decreased.
hypercalcemia.
Yes. Very good. Yes, correct. There is going to be thymus hypoplasia. What happened to parathyroid here? Hypoplasia. There is no thymus, cell mediated. Immunity is going to decrease, and with calcium level going to decrease or increase?
Decrease.
Here, decrease. And there will be decreased parathyroid hormone also. So what are the acute manifestations? So there's going to be perioral paresthesia, or a periungal paresthesia, decreased sensation around our mouth and decreased sensation around the nail or the fingertip. And then perioral paresthesia is an important term. So in the question, they can give you a clinical based question, and if you find a word perioral paresthesia as a clinical feature, please go for hypoparathyroidism, or they can give you syndromes, many syndromes, and they can ask you which syndrome is it. So Digeorge syndrome is going to be having a parathyroid hormone decrease or parathyroid gland hypoplasia. So you should apply the concept in that question like this. And then we have BP cuff, inflating proceo that is carpopedal spasm. If you cuff the BP machine, inflating, and it will lead to the spasm of the corpus or pedal area, and that is called as the obstetrician's hand. We have Chostak sign. This is tap on
Face,
anterior. Sorry?
face muscle twitching.
Correct, correct. Tap on the anterior border of parotid gland would result in contraction of facial grimacing or the twitching of the facial muscles. There can be stridor because of laryngospasm and the management is going to be IV calcium gluconate what will happen in the investigations. Calcium level is going to be decreased, phosphate increased, thyroid hormone is going to be decreased, and if you do a technetium system EV scan, there's going to be decrease uptake and last we have pseudo hypoparathyroidism. Here the parathyroid hormone values are going to be increased, but there is manifestations of hypoparathyroidism because parathyroid gland is going to act on a receptor. The receptor is resistant. And the resistance is because of KNAS gene. Parathyroid gland is normal. Parathyroid hormone is normal. But the receptor is resistant. Since the receptor is resistant, parathyroid is not able to increase your calcium levels. It is not able to act on the kidney, on the PCT, and not able to decrease your phosphate level. So, manifestation is going to be like a hypoparathyroid, but the serum parathyroid hormone level is going to be normal or increased. The clinical feature is going to be same like hypoparathyroidism. Investigation is important. Calcium levels is going to be decreased, phosphate is going to be increased, and your serum parathyroid hormone is going to be normal or increased. Do you understand this pseudo hypoparathyroidism, or shall I explain it again?
Sir. Understood.
Got it?
Yes, sir.
Okay. So next we will move to thyroid gland. Very, very important. Very important. Hyperparathyroidism. We will see that primary hyperparathyroidism. The most common cause is going to be your
Sir, it's hyperthyroidism,
Graves.
right?
Sorry.
It's hyperthyroidism, right? Hyperparathyroidism.
So it's hypothyroidism.
Sorry. Yeah. Okay. Hyperthyroidism. And in Graves' disease, it is autoimmune disease. And what is the antibody in Graves?
Lats.
Very good. LATs. What is the abbreviation? Tell me. Yes.
Long-acting thyroid stimulating antibody.
Very good. Long-acting thyroid stimulating antibody. This antibody is similar to TSH. So it's going to increase your T3, increase T4, and the TSH will What does the posterior pituitary secrete?
Oxytocin, ADH.
Correct. ADH, vasopressin, and the oxytocin. What is anterior pituitary secrete? We have two types of cells, acidophilic and basophilic. Acidophilic cell secretes. Yes.
Growth hormone.
Okay. Then correct.
ACTH.
Okay. Okay. We can memorize with the help of a mnemonic, a PG bought flat. A acidophilic, PG prolactin growth hormone. Bought B is basophilic and flat FSH, LH, ACTH and your TSH. Okay. So this is anterior and posterior pituitary. In anterior pituitary, we have acidophilic cells, basophilic cells. Acidophilic cells is going to secrete prolactin and growth hormone. Basophilic cells is going to secrete flat, FSH, LH, ACTH, and LH and TSH. For for secreting TSH, we have TRH coming from the hypothalamus. For secreting ACTH, we have ARH. So all these regulating hormones will be synthesized from the hypothalamus, sent to the pituitary gland, and from the pituitary gland, they will be secreted. In case of thyroid hormone, thyroid regulating hormone will be secreted from the hypothalamus, and when the thyroid regulating hormone comes to the pituitary gland, anterior pituitary gland, the basophilic cells is going to secrete your TSH, and this TSH is going to act in the thyroid gland. Thyroid gland then is going to secrete the T3 and T4. This T3 and T4 will act on various parts of our body, and it's going to help in your metabolism and many things. So this is how our pituitary gland works. So coming to the hyperthyroidism, primary Graves' disease. Graves' disease is an autoimmune disease. Autoimmune antibody name is long-acting thyroid stimulating antibody, and it is similar to TSH. Since it is similar to TSH, it is going to come to your thyroid gland and start stimulating the T3, T4 receptors, and they are going to secrete your T3, T4 outside the body. And we have something called as a negative feedback. What is this negative feedback? If there is increase in T3, T4, this T3, T4 is going to give a negative feedback. And this negative feedback is going to decrease it's going to give a negative feedback to pituitary, and this is going to decrease your TSH. The body will say we have enough amount of T3, T4. We have enough amount of T3, T4. Please don't secrete TSH. So this is the negative feedback, and the pituitary gland is going to decrease the TSH. Graves' disease, the same thing happens. The TSH is the long-acting thyroid stimulating antibody is similar to TSH, and is going to act on the thyroid, going to increase your T3, T4. And because of the negative feedback, TSH is going to be decreased. This is what happens in primary hyperthyroidism. Did you understand the concept?
Yes, sir.
Good.
Yes, sir.
So, any doubt? Shall I explain this again? So, we have pituitary gland, and in pituitary gland, we have anterior and the posterior pituitary. Posterior pituitary is going to secrete your antidiuretic hormone, vasopressin, and also is going to secrete your oxytocin. What happens if there is a decrease in ADH? Anyone? decreased vasopressin, or the posterior pituitary is not secreting enough amount of ADH, or the ADH receptor is malfunction in the kidney, what disease is going to be developed?
SAADH.
So no, please don't get confused. Antidiuretic hormone value is decreased. Antidiuretic hormone value is going to be increased. Antidiuretic hormone. The name says antidiuretic. Antidiuretic. Diuretic, water loss. Anti, no water loss. So, in case
Edema.
of, yes, correct. Antidiuretic hormone has decreased. If there is decrease in antidiuretic hormone, water loss will increase or decrease? That will be my question. With the name, you can understand antidiuretic. It is not going to let water go outside, but ADH here is decreased. So it is going to let the water outside, or it's not going to let the water outside. Okay. So
More water loss.
yes, there will be increase in water loss. The name says antidiuretic. Water loss will not be done by ADH, but this ADH is decreased. So there will be more water loss, called as the diuresis. Okay. Now what will happen to the serum electrolytes? What will happen in the body?
Decreases loss.
Sorry.
It will decrease or loss.
No, I'm asking what will happen to the serum electrolytes in the body, whether it will increase or decrease. See, there is water loss. Body is losing significantly. There is water loss. What will happen to the serum? Huh?
Saturation will be there.
Sodium will
Saturation.
decrease.
Sodium will decrease.
Yeah.
No. See, we'll have an example. We have a beaker which is having a 10-liter water, and the second beaker is having 8-liter water. We are adding, just for example, 2 kg of some electrolytes like sodium, potassium. We are adding. Same to the second beaker, we are adding 2 kg of the electrolytes. Now, which beaker will you say has lot of electrolytes, excess electrolytes on correspondence to the water present?
8 liters.
8 liters. Because the water is comparing to 10 liter, water is less, and we have the same amount of level of the electrolyte.
Hyposaturation.
Yes. So same thing happens here in your diabetes insipidus. In diabetes insipidus, antidiuretic hormone is going to be decreased. Because of that, there is going to be water loss. There is going to be diuresis or your polyuria. Hence the name diabetes. Diabetic mellitus also going to give you a lot of urine. There will urinate a lot. Polyuria will be there. In diabetes insipidus also there will be polyuria. Diabetes, the meaning is polyuria. So there is a lot of water loss. Serum electrolytes is going to be normal only. ADH does not have much action on the electrolytes. But since there is a lot of water loss, serum electrolytes in the body is going to be increased. Just with this example, you can understand what will happen in case of a syndrome of inappropriate antidiuretic hormone or SADH or CR. What will happen to the water loss? What will happen to the serum electrolytes? Yes. Water loss increase or decrease? Serum electrolytes increase or decrease?
Water loss will be decreased.
Water loss will be decreased. And the serum electrolytes? What will happen to the
Decrease.
serum electrolytes? Yes?
Decrease.
Yes. Normal or increase? Sorry, decrease. Can be normal or decrease. The water loss is going to be decreased. So there will be fluid retention. We have another beaker and this has 15 liter of water. Same 2 kg. This is what happens in CR. Water loss is going to be decreased. There is going to be fluid retention. There will be edema everywhere. The BP is going to be increased and the serum electrolyte is going to be normal or decreased. And here we have this important hypovolemic hyponatremia or sometimes euvolemic hyponatremia. This is ADH. So with the help of the function of ADH, you can understand, you can know what happens in diabetes insipidus, what happens in SADH. Okay, so posterior pituitary secretes ADH, vasopressin, and your oxytocin. Anterior pituitary is going to secrete your acidophilic, acidophilic and basophilic cells. Acidophilic cells is going to secrete prolactin and growth hormone. PG bot flat. PGA stands for acidophilic and PG prolactin growth hormone. Bot flat. Bot B stands for basophilic and basophilic cells is going to secrete flat. FSH, LH, ACTH, TSH. For secreting all these hormones from the pituitary, we should have a regulator, and the regulator is your hypothalamus. For example, in case of TSH, it's the hypothalamus for TSH to be released from the anterior pituitary from the basophilic cells. TRH should be released from the hypothalamus. This TRH will come to the anterior pituitary, come to the basophilic cells, and it will stimulate the TSH secreting cells. So TSH will be released and the TSH will come to thyroid gland and it will act on the thyroid gland and on its TSH receptors and increase the T3, T4 levels. If there is enough of T3, T4 in the body, increase in T3, T4 levels in the body, this T3, T4 will give a negative feedback to the pituitary gland. And this negative feedback will decrease your TSH. Understood? So this is primary hyperthyroidism, Graves' disease. We also have secondary hyperthyroidism. And the cause most common is going to be due to a pituitary adenoma. And here TSH is going to be increased. T3, T4 is also going to be increased. There is a tumor in the pituitary gland. For example, a tumor in the basophilic cell, and that cell is going to secrete your TSH. So this tumor is going to secrete your TSH a lot, and this TSH is going to come to the thyroid gland and stimulate TSH receptor, which is going to increase the T3, T4, which is going to secrete T3, T4 from your thyroid gland. This is secondary hyperthyroidism. and is most commonly due to your pituitary adenoma. And then we have, this is primary hyper and secondary hyperthyroidism. Then we have toxic nodular goiter, and in the scan, if there is a warm nodule, it is a normal thyroid. There is cold nodule, it's going to be a cancer, and a hot nodule is going to be a overactive tissue. There can be increase in thyroid hormone because of the cancer of the ovary. You would have learned stroma ovary, and the stroma ovary sometimes secretes TSH, sometimes secretes thyroid hormones too. Then you have gestational trophoblastic neoplasia, and here your HCG is going to be increased, and the TSH will also be increased. Clinical features of hyperthyroidism: T3, T4 are sympathomimetic agents. So palpitation is going to happen because of the stimulation of beta 2 receptors pharmacology. Fine tremors is going to happen, sweat, hypertension because of alpha 1 receptors. Thyroid hormone is going to increase your basal metabolic rate, leading to weight loss.
So sorry for interrupt. Actually, palpitation,
Yes.
it should be beta 1, right? Actually, beta 1 is located in heart, maybe.
No, beta 1 we have both in the beta 1 has in the heart. Also, beta 2 also is present in the heart. Beta 1 receptors is going to decrease the heart rate and increase the blood pressure. Right?
Yes, sir.
Okay.
Beta 2 would be for fine tremors and beta 1 for palpitations, sir.
Okay. Fine tremors also it is due to beta 2 only. And the palpitation I will clarify and tell you guys. And it's also calorigenesis increases your causes heat tolerance, and in the eye proptosis leading to exposure keratitis, and this leads to the, because of the exposure there is inflammation of cornea. And investigations, TFT, total TT, T4 is going to be increased, and your free T3, T4 is also going to be increased. With the help of TSH levels, if the TSH level is going to be decreased, it is Graves' disease, and the TSH levels also increase, then it is pituitary adenoma. Primary, this is secondary. In case of pituitary adenoma, MRI head should be done. And in case of Graves' disease, lax antibody titer should be done. Thyroid scan should be done. The treatment of Graves is going to be anti-thyroid drugs, propyl thiouracil. This is safe in pregnancy or in breastfeeding. And
Carbimazole.
correct. Carbimazole. Carbimazole pregnancy can be used.
Not in first trimester.
Second and third can be used.
Second and third
Sorry?
trimester.
Yes, correct. Second trimester we can use. What is the important side effect of carbimazole? Or a dose limiting side effect? Agranulocytosis. Decrease TC, decreased your neutrophil counts. And in case of secondary, the management is going to be a transsphenoidal resection. Next we go for hypothyroidism.
So don't we do radioactive ablation? Radioactive.
Yeah, ablation can be done, surgery can be done. Those are surgery questions, so I didn't cover much.
Yes.
Transsphenoidal surgery can be done, ablation can be done.
Okay, sir.
We don't have enough of time, so I can't cover everything. So hypothyroidism, primary, we have secondary. Primary is going to be gland involvement, here the T3, T4, TSH. T3, T4 is going to be decreased. TSH is going to be increased. Secondary is pituitary involvement, and here TSH, T3, T4, all values is going to be decreased. See the causes. In India, yes, anyone? Causes? Cause for primary hypothyroidism in India?
Hashimoto's thyroiditis.
Hypothyroidism.
Very good, very good. Hashimoto thyroiditis. Globally, because of the deficiency of iodine, endemic goiter. Iodine deficiency. Drug amiodarone can cause both hyperthyroidism. So this is primary hypothyroidism causes, and secondary causes postpartum hemorrhage. What syndrome is it? Leading to hypopituitarism, postpartum hemorrhage, decreased blood supply to the pituitary gland, and the pituitary gland is going to undergo necrosis. What is it? Syndrome? Sheehan's. Yes, correct. Sheehan syndrome. It is a hypopituitarism. All the pituitary hormones will be decreased here. This is obstetric cause. Non-obstetric can be due to hypertension, trauma to pituitary gland, radiation, sarcoidosis. This is the cause for secondary hypothyroidism. Clinical feature, there will be heat. There was heat intolerance. Here it will be cold intolerance. There will be edema, called as the mixed edema. It involves scalp, going to cause alopecia or hair loss. Face, puffy face, vocal cords, hoarseness of voice, body is going to be a thick or a coarse skin, gut is going to be constipation. Constipation is one important complaint given by a hypothyroid patient. And next to mixed edema, there can be infertility, headache, so investigation, the TFT, thyroid function test, total T3, T4 is going to be decreased, free T3, T4 is going to be decreased again, and TSH, primary, secondary. Primary is due to the gland, secondary is due to the pituitary. Here we will have the yes, Hashimoto thyroiditis. What is the antibody? Name of the antibody?
TPO antibody.
Yes, correct.
Anti-TPO.
Yes. Anti-TPO antibody will be seen. And here MRI head should be done for locating any bleeding or any trauma to the pituitary gland or necrosis of the pituitary gland can be found with the help of MRI brain. The treatment of hypothyroidism is going to be yes,
Levothyroxine.
yes. So Eltroxin or levothyroxine will be given. So I will stop endocrinology from here. We will start pediatrics. We'll take a short break for 2 minutes and we'll resume.
Okay, sir.
Yes, that tachycardia, bradycardia, the receptor involved is beta 1 and not beta 2. Sorry for that mistake. Not beta 2, beta 1 is involved for the heart. Beta 1 is present in the JG apparatus and in heart. Pediatrics. Coming to pediatrics, the growth and development, milestones, very important. Just mug up the timing, year, which month, milestone. They have asked social smile. When the social smile comes, usually anyone?
2 months.
Sorry?
2 months.
No, not 2. Three months. Social smile comes in 3 months. Milestones are important. Neonatology is very important. Cardiology can get about 8 to 10 questions. Pediatrics and medicine, you can get about 30 to 40 questions from medicine. In the morning session of your exam, maximum number of questions will be coming from SPM or PSM, preventive social medicine, you will be getting. And in the afternoon session, Maximum number of question will be seen in OBG for sure. Next to OBG, medicine surgery question will be a lot. Psychiatry, dermatology questions will be coming here and there, 4 to 5 questions like that. So afternoon session subject OBG, surgery, internal medicine, 3 subjects should be concentrated much more, very much. If you completed all these 3 subjects, surely it's going to get you, just from these 3 subjects, it will get you more than 80 to 90 marks, only from these 3 subjects. So we'll start with neonatology, neonatal sepsis. Definition: any systemic bacterial infection in a neonate. Classification: early onset sepsis, and it is most common seen in the first 72 hours, and these organism causing the sepsis, organism responsible are usually derived from maternal genital tract, like group B, strep, E. coli, Klebsiella. Risk factor: if the mother has a fever, if the liquor smells bad or a foul smelling liquor is present, or premature rupture of membrane, and then during delivery, difficult or a prolonged labor can cause neonatal sepsis, or a multiple pervaginum examination is also a risk factor. And from the baby, if the baby is having a low birth weight or prematurity, these are the early onset sepsis and late onset sepsis. The organism is usually acquired from the environment, community acquired, hospital occurred. Community occurred, most common. Staph aureus, then E. coli. Hospital occur, Acinetobacter. Klebsiella. And here, meningitis is commonly seen. The risk factor for late onset is going to be lack of breastfeeding, multiple needle pricks, superficial infection involving skin or the umbilical cord stump, low birth weight, prematurity. This question has been asked. Most effective or the important method to prevent neonatal sepsis. Yes, anyone? Proper hand washing of caregivers. This question has been asked in FMGE, also in NEET. Coming to the clinical features, there's going to be poor feeding, or there will be a alteration in already established. Previously, the baby will be accepting the feed. He or she will be normally taking the feed. So there can be a alteration in an established feed because of an sepsis. Alteration in established feeding behavior. This will be seen earliest. Later, the poor feeding will come. Then temperature disturbance will be seen. More commonly, hypothermia will be seen than with the fever. Respiration, there can be shortness of breath, can be hypoxia, or there can be tachypnea, and CNS irritability can be seen, or shrill cry, seizures can even happen. GI, abdominal distension, fecal intolerance, metabolic, there can be hypoglycemia, metabolic acidosis. There is a severe sepsis. There can be septic shock, multiple organ dysfunction, scleroderma. It is a generalized non-pitting that is seen in neonates with severe sepsis. So this scleroderma. These are the clinical features. Next, we have diagnosis, definitive blood culture, screening, sepsis screen, and the components. Any 2 out of 5 present, then it is positive sepsis screening. And the components TLC, total leukocyte count increased, ANC increased, IT ratio, it is immature with total neutrophil ratio increased, ESR increased, and the C reactive protein or CRP increased. If any 2 out of 5 is positive, then it is a positive for a sepsis screening. Supportive test we can go for check the baby's blood glucose level, a chest X-ray, and lumbar puncture and CSF study in case of meningitis. Then the treatment. Coming to the treatment part, supportive care. First, shift the baby to a nursery or a neonatal intensive care unit. Start IV fluids. Maintain the glucose levels. Maintain the normal temperature. Keep monitoring the baby. After supportive, we have specific treatment, IV, empirical, broad spectrum antibiotics should be used, like injection, ampicillin with gentamicin, injection,
Tazobactam.
sorry,
Piperacillin and Tazobactam, sir.
sorry, I can't get you.
Piperacillin and
Piptas.
Tazobactam.
No, Piptas, tazobactam can be used, but if it is resistant to your ampicillin, gentamicin, then you go for Piptas.
Okay, sir.
So start with ampicillin, gentamicin, and resistant, then you go for a higher, broader spectrum antibiotics. Piptas, tazobactam also have a lot of side effects
Okay, sir.
comparing to the ampicillin. So start with ampigenta, then go for Piptas. And injection cefotaxime if meningitis is present or suspected. The duration, how much duration the antibiotics should be given is important. So duration of antibiotics, sepsis, screening, blood culture, CSF analysis suggestive of meningitis. If the sepsis screening is positive, blood culture is negative, CSF is not suggestive, duration of antibiotics should be 1 week. Sepsis screening plus positive or negative, but your culture turns out positive, CSF is not suggestive of meningitis, then you go give the antibiotic for 2 weeks. Sepsis screening, positive or negative, culture, positive or negative, but if the CSF analysis is suggestive of meningitis, you should give it for 3 weeks. So this is one important clinical based question chart. I can ask you clinical based question like sepsis screening turns out positive, but the blood culture and CSF analysis is negative, turns out to be a negative. How much duration will you give your antibiotic? So duration 1 week, that is important. Then we can go to, we'll try to cover some important aspect. Okay. Infant of diabetic mother. There is a diabetic mother and she is giving to birth to a child, and what can be the clinical manifestation that can happen because of the sugar levels of the mother. So we have a pathophysiology, This is Peterson's maternal hyperglycemia hypothesis. There is maternal. This hypothesis says if the mother has hyperglycemia, the fetus is going to have hyperglycemia, and because of this hyperglycemia of the fetus from the mother's hyperglycemia, fetus body is going to increase the insulin, and there is fetal hyperinsulinemia. So there is fetal hyperinsulinemia, and the fetus gets delivered. Still, the insulin levels inside the body of the fetus will be same, and after delivery, the neonate's insulin level is also going to be increased, leading to neonatal hypoglycemia. And also, insulin acts as a growth factor. Insulin is an important growth factor for fetus. So, this insulin is going to cause macro all organs are going to increase in size, except for the brain. So this is macrosomia, and increase in extra medullary hematopoiesis, leading to polycythemia, neonatal hyperbilirubinemia, so polycythemia, you can see increase RBC. If there is increased RBC in the blood, the resistance is going to increase inside the blood vessel. If the resistance is going to clot. So there's going to be a thrombus formation. This thrombus can lodge in anywhere, can go to brain, cause stroke, can go to heart, can cause a heart attack. So this is Pedersen's maternal hyperglycemia hypothesis. So in case of insulin diabetic mother, problems what she will face. So the baby is big in size. So macrosomia is going to lead to a difficult or a prolonged labor There can be a perinatal asphyxia for the mother. There is increased chances of birth trauma. And then respiratory system, more chances of respiratory distress. Next, we will go for some important scores in neonates. Apgar scoring is very important. So, Apgar score components, we'll score it as 0, 1, and appearance 0 if completely pale or blue, 1 if the appearance body is pink but the extremities are blue, 2 if completely pink or red. Pulse rate absent less than 100 per minute, minute. Grimaces, grimace, no response, 0. Grimaces, only cough or sneezes is going to get a score of 2. And this grimace is a response to stimulation of the oropharynx by a catheter. So this grimace is done with the help of a catheter and the oropharynx will be stimulated. Next to grimace, activity, flaccid is going to get a 0. Some flexion, 1. And actively moving baby will get a score of 2. Respiratory effort, none. There is slow and irregular breathing, 1. And there is normal or a strong breathing, going to get a 2. Maximum score will be 10. The minimum score is going to be 0. The score is more than 7, normal. If the score is 0 to 3, is going to birth severe birth asphyxia. Apgar score is usually documented at the first minute and 5 minutes or fifth minute of life. It has no role in resuscitation, and the score is done usually for a prognosis. Thus, prognostic importance. So this respiratory effort question you must have seen a lot of times. Respiratory rate, respiratory effort. Those type of questions has been asked a lot of times. They won't be asking you this like this respiratory effort or respiratory rate. They will begin to give clinically that the baby is completely blue or the body is pink and the heart rate is this much, the grimace is this much, there is no flexion, there is baby is flaccid. So those kind of scoring you have to make. So nowadays they are asking like that. So Apgar scoring is very important. This question has been asked not much and not many times. So this is important. It has no role in neonatal resuscitation and it has prognostic importance. It's also important. Next, we have Silverman score. The scoring is very, very important. Surely one question will be coming. Just they might ask you, they will give you a lot of names of a score and they will ask you which score is used for this, that kind, or as a clinical question, like I told before, they will give you a baby with this much grimacing or this much respiratory effort, so heart rate, and you should give you a score. Surely in pediatrics, you will get a question based on score. Silverman score. It is used to assess the respiratory distress. Not going into detail of this, don't have much time. The Silverman score is important, and the Silverman score is used to assess the respiratory distress in a preterm neonate, and in case of a term neonate, down score is used. Next we move on to some respiratory disorders, RDS or respiratory distress syndrome or hyaline membrane disease. Most common cause of respiratory distress in a preterm neonate is going to be RDS, and the basic defect is going to be deficiency of surfactants. Surfactant, composition of the surfactant are PPPC, dipalmitoyl phosphatidyl choline, or lecithin. Lecithin is most important composition, and then we have phosphatidyl cerol, cholesterol, and few surfactant proteins like protein A, B, C, and D. Yeah, the B is very important, most important surfactant protein. Synthesis of surfactant. It begins in fetal lungs around 20 weeks of gestation, and it begins to appear in amniotic fluid by around 28 to 32 weeks of gestation, and the mature surfactant in adequate amount will appear in about more than 35 weeks of gestation. And the function of surfactant is to decrease the surface tension of alveoli, or to prevent the alveoli from collapsing during expiration. Pathophysio of RDS. There is deficiency of mature surfactant, so the alveoli collapses. There is going to be a diffuse alveolar damage leading to edema of the interstitial edema, and last there will be deposition of fibrin. And when a lung biopsy is done, there will be a eosinic hyaline membrane. Clinical feature, preterm neonate born at less than 35 weeks of gestation, presenting with respiratory distress soon after birth, with typical chest X-ray findings. And this chest X-ray findings are going to be ground glass haziness of lungs, presence of air bronchogram, reticulonodular appearance, there can be a features of lung collapse. A diagnosis, with the help of clinical feature, with the help of chest X-ray, the ways to detect adequate surfactant in amniotic fluid. We have Nile blue sulfatase test, detect the lung maturity. We have shake test, in the shake test, we take a test tube, we add ethyl alcohol and amniotic fluid will be added. After at 1 minute, sorry, if there is one or more than one complete ring of bubbles on surface is formed, if a bubble is formed on the surface, one or more than one, then it is going to be a mature surfactant. Treatment, is going to be supportive care, specific management, mild, if there is mild RDS, CPAP, continuous positive ARB pressure, there is moderate to severe RDS, then we go for intratracheal surfactant with respiratory support, either CPAP or mechanical ventilation with O2. How do we prevent? Prevention of RDS is the help of antenatal cortico and the indication is to all pregnant ladies who are expected to deliver between 24 to 34 weeks. The steroid like injection beta methasone, injection dexazone can be used. Betamethasone 12 milligram dose IM, 2 doses should be given and 24 hours. Just a minute. So betamethasone 12 milligram IM dose, 2 doses will be given 24 hours apart, 1 day apart, and the dexamethasone dose will be 6 milligram IM, 4 doses and 12 hours apart. Preference betamethasone is preferred because it has slightly neuroprotective effect too. So here we conclude. Please read endocrinology very well, what we learned today and what all is left over. Please finish hyperthyroidism, hypothyroidism, what are the causes, how you manage, how you can answer clinically. Please do some questions. And pediatrics, neonatology is very important. Milestones, growth and development, scoring is very important. Please go through it. And as I said earlier, concentrate more on during the revision time, concentrate more on PSM, OBG, medicine, surgery, 4 subjects. Top priority should be given when you are revising. And today it is 21st, so not even, you have like 15 days, 20 days only you have. This last time just before the exam, please don't get distracted by others in your family or by other friends or someone asking you questions and you couldn't answer. Please don't get down because of that. The 3 hours examination is the important period. That time you should answer correctly. That is the most important thing. Morning, afternoon, 150, 150. In that 150 question, you should not commit mistake. Just before the exam, you can commit, but during that year time, you should not commit. Please answer. You have 1 minute for each question. Take your time. Don't rush. Please read the question slowly. Read the options correctly. Think, close your eyes. Think what will be the answer. Then choose the option. Just by seeing the question, please don't answer and go to the next question. Just like that, in a second, take 1 minute. There is 1 minute for each question. If you come to NEET PG, there is not 1 minute. Same 300 question, you should write in 3.5 hours. The time reduction will be very much. You will have like seconds only. So you won't have a minute. So please just think, write your exam. Don't change the options. Already you have marked. If you are confused, usually the first option you marking will be the right. So we'll see OBG again today evening or maybe on Tuesday. I will tell you guys. So all the best. Read well. Revise today. Thank you for listening.
Thank you, sir.
Thank you.
Thank you, sir.